Good day. Today I will walk us through a concise but broad overview of antibacterial agents, how they arose historically, the major classes and their origins, key pharmacological principles, their clinical uses, and finally principles guiding rational therapy, especially in the context of rising antimicrobial resistance. So the introduction of antibiotics into clinical use represents the greatest medical breakthrough of the 20th century. Beyond treating infectious diseases, antibiotics enabled many of the modern medical procedures we take for granted today, such as cancer chemotherapy, organ transplantation, open heart surgery, intensive care, major trauma surgery, and others. Over the past century, antibiotics have had a profound effect on human longevity and global public health. The first widely recognized antibiotic or antimicrobial was arsphenamine, or what we call salvarsan, which was deployed in 1910 for treatment of syphilis. However, a few decades later, synthetic sulfonamide drugs emerged, the first broadly effective synthetic antimicrobials. While in 1928, Sir Alexander Fleming observed that a mold, later identified as a species of Penicillium, inhibited bacterial growth in a contaminated petri dish, the now famous discovery of penicillin. A decade later, penicillin was purified and developed into a clinically usable drug, a landmark moment that began what is known as the golden age of antibiotic discovery. So from the 1940s through the 1960s, a flood of new antibiotic classes entered clinical use, essentially forming the backbone of all antibiotic families we still rely on today. The soil derivative filamentous bacteria, the actinomycetes, particularly the genus Streptomyces, played an outsized role. More than half of all naturally derived antibiotics used clinically were produced by actinomycetes. And under the leadership of Selman Waxman, systematic screening of thousands of soil bacteria, otherwise called the Waxman platform, yielded multiple antibiotics, including streptomycin, the first antibiotic that was effective against tuberculosis or TB, as well as neomycin, actinomycin, and numerous others. These discoveries transformed the management of bacterial infections across the board: gram-positive, gram-negative, anaerobes, mycobacteria, and others. And as you can see here, starting from penicillin, sulfonamide, and then later on from the 1940s to the 1960s, there was a boom of discovery of many different antibiotics. After the 1960s, going to the 70s, 80s, 90s, 2000s, just a sporadic number of new antibiotics were discovered and beyond. And as I mentioned, by the late 1960s onward, the pace of discovering novel antibiotic classes slowed dramatically. This was partly due to diminishing returns. Many easy-to-cultivate soil microbes had already been exhaustively screened. Subsequent screens often rediscovered known compounds rather than truly novel ones. Meanwhile, bacteria continued to evolve mechanisms of drug resistance, reducing the effectiveness of once reliable drugs and leading to modern antimicrobial resistance crisis. Thus, although antibiotics remained foundational, the diminishing pipeline for new classes plus rising resistance means that formerly treatable infections are now harder to treat. Okay, so antibiotics in their classical sense are often natural products or secondary metabolites produced by microbes, not to benefit humans, but likely for ecological competition, microbial chemical warfare, defense, signaling, and predation. The soil-dwelling actinomycetes, like streptomyces, appear genetically wired for this. Many have large genomes encoding multiple biosynthetic gene clusters or BGCs, enabling production of many different natural products. It is now known that microbes often encode more natural products than they actually produce in lab conditions. Many BGCs, or the so-called biosynthetic gene clusters, remain silent under standard laboratory cultivation. This hidden biosynthetic dark matter, the untapped natural product potential, has renewed interest in exploring undersampled environments like marine sediments, unusual ecological niches, symbiotic microbes to discover novel antibiotic scaffolds. And there on the right, we see the actinomycetes, right? And there are many different, steps in its life cycle. And it's really on the last part, no? After the substrate mycelium is formed, that antibiotic production occurs. And similar to that, no, how do they really make penicillin? No? Of course, it starts with the penicillium mold that naturally produces the antibiotic penicillin, and scientists learned how to grow the penicillium mold, through a fermentation tank. No, this process increased the growth of penicillium, and then number three, the scientists separated the penicillin product from the mold. Finally, the penicillin is purified for use as an antibiotic medicine. So very interesting. Now the following is a summary of major antibiotic classes, and we shall just go through them and not really delve too much, because you really, as you go along, you will really need to build your library of knowledge with regard to the classes of antibiotics, the members of the classes and their uses, and of course side effects. No? So here we start with the aminoglycosides, no? Infection usually used for infections caused by gram-negatives, E. coli, Klebsiella, and then streptomycin and kanamycin also was used in the past as anti-TB agents. Note the side effects: hearing loss, vertigo, kidney damage, that should be monitored. No? It doesn't happen to all, but it may happen to some. That's why these side effects should be discussed with patients. Now, cephalosporins are, they're from first generation going up, and it's best to know here, most important in the first generation are cefazolin and cephalexin, and these ones, are more for gram-positive bacteria and minimal gram-negative, but mostly for gram-positive. Second generations, there is an increase in gram-negative coverage, still with gram-positive, but slightly less than when you compare to the first gens. And for the third generation, there's an increase in coverage to gram-negative, a further slight reduction in gram-positive. Note the similar side effects: GI upset, diarrhea, nausea. Of course, allergy should always be watched out for. Now, fourth generation cephalosporins, cefepime. Now, yes, so this is even more gram-negative coverage, especially Pseudomonas. In the third generations, not all the third gen have Pseudomonas coverage, but ceftazidime also has. No, but again, ceftazidime, third gen, fourth gen cefepime has Pseudomonas coverage. Again, as you go up the generations, especially up to the fourth, you lose more gram-positive coverage but gain more gram-negative coverage. However, there's a slight difference, no? When you talk about ceftaroline. Ceftaroline is like a third generation antibiotic, no Pseudomonas coverage, but with coverage for MRSA or methicillin-resistant Staph aureus. Now, more recently, we have been lucky because now we have even higher generation cephalosporins such as ceftazidime avibactam, which now has a role for drug-resistant gram-negatives, while ceftolozane tazobactam is more for drug-resistant Pseudomonas. Now for the glycopeptides, vancomycin and teicoplanin, glycopeptides are more, have better coverage for MRSA, methicillin-resistant Staph aureus, and also for enterococci. Now we'll skip the one in the middle, but carbapenems are really what we have. One of the highest, medications that we have that has good coverage with gram-positive, but not for resistant gram-positives, but also for gram-negatives, including resistant gram-negatives such as ESBL. So here, ertapenem, imipenem, and meropenem are shown. We can put their doripenem also there. The difference is that ertapenem does not have Pseudomonas coverage, while imipenem, meropenem, doripenem all have Pseudomonas coverage. Watch out for seizures, although that's, it happens in some patients, but not in all. Now, macrolides are the following: azithromycin, clarithromycin, and the old erythromycin. And you will use this a lot, because it's very active and easy to prescribe for upper respiratory tract infection. Just make sure they're bacterial upper respiratory tract infection. And in pneumonias also, you can give that, but for atypical coverage, especially in moderate risk pneumonias and high risk pneumonias. Now, monobactam is the one medication under it is aztreonam, a medication built for gram-negative infections, including Pseudomonas. Now, the penicillins, of course, we mentioned penicillin before, and these are the many different penicillins available: amoxicillin, ampicillin, cloxacillin, which is has good coverage for methicillin-susceptible Staph aureus, which is also equivalent to dicloxacillin, flucloxacillin, and then the IV forms are nafcillin or oxacillin, not shown here. Penicillin can be oral or IV. Piperacillin is also a penicillin. Now, when you combine it with tazobactam, it increases the broad coverage, and that one has Pseudomonas coverage, even Enterococcus coverage, and then the polypeptides, of course, colistin and polymyxin B are one of the older drugs, that are very good for gram-negatives, but because of potential side effects, they are now, they have now become second line, since we mentioned that there are newer agents, such as ceftazidime avibactam or ceftolozane tazobactam that are now, have less side effects compared to the colistin and polymyxin B. Okay, sulfonamides will, of course, the classic one here is trimethoprim sulfamethoxazole. But again, you watch out for allergies. It is known for at times causing Stevens-Johnson, but it's very effective against urinary tract infection. But it also has MRSA coverage, also has pneumocystis coverage. So many different, although it's known for some side effects, it also is broad enough to cover many different diseases also. Now, fluoroquinolones, of course, ciprofloxacin is there, levofloxacin, and then moxifloxacin. I don't think it's there, but from cipro to levofloxacin, the respiratory fluoroquinolones are levofloxacin, moxifloxacin, but cipro is more for gram-negatives. Levofloxacin still good for gram-negatives, but now has some gram-positives. When you reach Moxifloxacin, there's some reduction in gram negatives, and it has better coverage for gram positives. When that's moxifloxacin. Now for the tetracyclines, we have minocycline. Doxycycline is not there, but tigecycline is the newest one. It's intravenous and it has broad spectrum except for Pseudomonas, no? Although it's good for many resistant gram negatives, and it also has methicillin resistant Staph aureus coverage. Now these are the others that that can be used, no? But as I won't go into them. As you go along with your clinical practice and or training, no? You have to be able to know the features of these medications, their coverages, their potential side effects. No? All right. Now we go to clinical indications and principles of therapy. No? When selecting and prescribing antibiotics, there are several core principles that should guide our decision making. Number one, pathogen identification and likely susceptibilities should be considered. No? So whenever possible, make therapy targeted to avoid unnecessary broad-spectrum use. Number two, pharmacokinetics or pharmacodynamics, shortened form PK/PD. So consider the drug class, the mechanism, whether time-dependent or concentration-dependent, and then tissue penetration, the distribution, renal or hepatic clearance, and of course toxicity profile. No? And then number three, the duration of therapy. Use always the shortest effective duration to limit toxicity if possible, and also to reduce selective pressure for resistance. No? So we'll go through PK/PD in a bit. Number four core principle, stewardship and combination therapy. We should avoid misuse, overuse, or underdosing. Consider synergy or combination therapy, especially in severe infections, resistant organisms, or to prevent resistance emergence. No? So very important. Number five, the host factors. No? So immune status, comorbidities, organ function, potential drug-drug interactions, allergies, and site of infection are all considerations. No? And surveillance and microbiology support, use cultures, susceptibility or sensitivity testing, local antibiograms, and adjust therapy accordingly based on results. No? Remember, antibiotics are powerful tools but also a finite resource. Their value must be safeguarded with judicious, evidence-based use. Okay, so the remarkable period of antibiotic discovery has, as we mentioned earlier, has tapered off, while bacterial pathogens have continued to evolve resistance, and that puts enormous pressure on our current antimicrobial therapy. Many of the old classes remain in use, but their efficacy has eroded. Multi-drug resistance highlights including MRSA, drug-resistant gram-negatives, and others. The antibiotic development pipeline has shrunk, and relatively few truly novel classes have been introduced over the past several decades. This gap poses, a severe risk. No? Growing resistance and declining drug discovery is really a risk that is there and is real. Some actually fear that there is a post-antibiotic era that has started unless action is taken. So, encouragingly, recent advances and renewed interest in natural product discovery suggest that the future may yet hold new antibiotic classes, particularly, as we mentioned earlier, from previously underexplored environments. Modern technologies, genome mining, heterologous expression of silent biosynthetic gene clusters, as we mentioned, the BGCs, exploring microbial symbionts, marine, insect, plant-associated ones, revisiting un- or undersampled ecological niches, are reviving the potential to harvest novel natural products. There are also new drugs in clinical trial pipelines, including compounds with novel modes of action, though many are still derivatives rather than entirely new classes. However, scientific advances alone are not enough. To translate these discoveries into clinically approved antibiotics, changes in financial, regulatory, and incentive models are needed. Alright, so before delving deeper into antibacterial therapy, it is useful to remember that the terms antimicrobial, antibiotic, and anti-infective are broader than just antibacterial. So these terms encompass drugs that target bacteria, fungi, viruses, and parasites. However, because antibacterial agents remain by far the most commonly used in clinical practice, our focus today remains on antibacterial therapy. The principles we discuss often apply in modified form to other anti-infectives. Clinical practice in infectious diseases is ideally guided by evidence-based guidelines, such as those published by the Infectious Diseases Society of America, and here locally, the Philippine Society for Microbiology and Infectious Diseases, but always interpreted in the context of individual host factors such as comorbidities, immune status, response to therapy, and cost or availability of agents. So the first critical step is obtaining an accurate infectious diseases diagnosis. This includes identifying the site of infection, defining relevant host factors like immune-compromised state, diabetes, advancing age, and whenever possible, securing a microbiological diagnosis through culture, microscopy, or even serology. This is especially important for serious or prolonged infections like endocarditis, septic arthritis, vertebral osteomyelitis, disc space infection, meningitis, because the treatment is longer than the usual, no? And therefore you will be committing a patient to prolonged antibiotics if you do not, if you just presume. It's always better to make the diagnosis. So proper specimen collection and prompt submission to the microbiology lab should ideally occur before starting antibiotics, because the first dose may suppress bacterial growth and compromise diagnostic yield. Also important will be a detailed patient history, including exposures like travel, environmental, endemic regions, or risk factors. These can guide likely diagnoses even when cultures are unavailable or delayed. But we must also be cautious. Not all clinical presentations with fever, inflammation, or infectious-looking signs are infections. Non-infectious conditions like inflammatory, autoimmune, neoplastic should remain in the differential, especially when diagnostic clarity is lacking. So the urgency of antibiotic initiation depends heavily on clinical context. In critically ill patients, empiric antimicrobial therapy should be started immediately after or concurrently with obtaining diagnostic specimens. In more stable patients, it may be appropriate and safer from a diagnostic standpoint to delay antibiotics until adequate cultures or biopsy samples have been obtained. Premature therapy may hinder the ability to identify the causative organism, complicating long-term targeted therapy. This balance between act fast and diagnose well is a central tension in antimicrobial stewardship, and understanding it is foundational to safe, effective therapy. So, given that microbiological results like culture and susceptibility often take 24 to 72 hours, even 5 days after, initial therapy is often empiric, based on clinical syndrome, and of course likely pathogens, host risk factors, and local epidemiology or antibiograms. Broad spectrum agents, sometimes in combination, are commonly used. And once microbiology and susceptibility data are available, therapy should be narrowed. This is called de-escalation, to target the identified pathogen using the narrowest, effective, least toxic, and most cost-effective agent. This improves safety, avoids unnecessary broad-spectrum exposure, reduces toxicity, and helps curb emergence of resistance. Of course, the choice of empiric therapy should consider the site and severity of infection, host-specific risks, resistance, prior antibiotic exposures, and local resistance patterns. For example, in hospital-acquired infections or in patients with prior broad-spectrum antibiotic exposure, empiric regimens may need to cover multi-drug-resistant organisms and or Pseudomonas. Alright, so once the infecting organism is identified, labs perform antimicrobial susceptibility testing or AST to determine whether the organism is susceptible, intermediate, or resistant to a given antibiotic. The key metric is the minimum inhibitory concentration, the lowest drug concentration that inhibits visible growth in vitro. A susceptible result implies that usual achievable serum or tissue concentrations with standard dosing are likely effective, but MICs of different drugs are not directly comparable. So MIC1 of 1 for drug A, for example, versus MIC2 for drug B does not mean that drug A is twice as active. Importantly, susceptibility in vitro doesn't always guarantee success in vivo because drug penetration to the site of infection, local conditions such as pH, oxygen, protein binding, host factors, and presence of foreign bodies or biofilms all influence efficacy. So here is just an example of a blood culture result with susceptibility. So you have the drugs there on the left side, such as ampicillin, vancomycin, cefazolin, down the line. And there on the right side, ampicillin is R, meaning resistant. Vancomycin is S, so the bacteria, specifically Staphylococcus aureus, is susceptible, or S, sensitive to vancomycin. And again, cefazolin, the Staph aureus is resistant to cefazolin, and down the line. So some antibiotics are classically described as bactericidal, drugs that kill bacteria, such as many beta-lactams, aminoglycosides, fluoroquinolones, cell membrane agents, whereas others are bacteriostatic, inhibiting growth, such as protein synthesis inhibitors. However, the dichotomy is not absolute. The same agent may be bactericidal under certain conditions, bacteriostatic under others. In vitro versus in vivo behavior may differ. Now, in severe infections like endocarditis, meningitis, immunocompromised hosts with infections, bactericidal agents are often preferred to maximize the speed and likelihood of bacterial eradication. So antimicrobials differ in how their effectiveness relates to drug concentration over time. Some are time-dependent killers, meaning the efficacy depends on the time above the MIC, especially many beta-lactams and vancomycin, while others are concentration-dependent, which means their efficacy depends on the peak the concentration is, like aminoglycosides, fluoroquinolones, daptomycin. Thus, with time-dependent agents, as we see here, frequent dosing or continuous infusion may maximize the time above the MIC. And you see there time above the MIC. So see the graph is above the MIC for a significant amount of time. And the more time that the concentration is above the MIC, not necessarily too high concentrations, but it's the time element, the killing is better. Versus concentration-dependent agents achieving a high peak concentration, as you can see there, the first peak is the most important rather than the dosing frequency. So that that vertical peak, above that MIC line, is more important. So next we go here, drug penetration to the site of infection is also critical. Some tissues or compartments like CSF, bone, abscesses, prostate, foreign body surfaces, biofilms are challenging. Serum levels alone may not reflect effective local concentrations. This may require selecting agents known to penetrate the relevant tissue, using higher doses or combining therapy with non-pharmacological measures, especially if it can be done. Source control and drainage are very, very important. So although monotherapy is often preferred, there are several clinical situations in which combining antimicrobials makes sense. So first, empiric therapy in critically ill, hospitalized, or immunocompromised patients to maximize the likelihood that at least one agent will hit the causative pathogen or pathogens, especially when resistant organisms are possible, such as in hospital-acquired infections. Next, synergistic activity. Some combinations produce synergistic killing, like a cell wall active drug like a beta-lactam plus an aminoglycoside may kill certain bacteria more effectively than either alone, notably in certain enterococcal or streptococcal endocarditis. Third, polymicrobial infections, when more than one organism type, like aerobic gram-negatives plus anaerobes, is suspected, such as intra-abdominal infections, combination therapy may offer broader coverage than a single agent. Then last, preventing resistance emergence. So using two agents with different mechanisms may reduce the chance that resistant mutants arise by making it less likely that a single mutation confers resistance to both. This principle underlies combination regimens in diseases where long duration of therapy is anticipated, like in tuberculosis or in high-risk patients. However, once microbiological and susceptibility data are available, clinicians should aim to narrow therapy, de-escalate, if possible, to minimize toxicity, cost, and selective pressure for resistance. Now, when selecting an antimicrobial regimen, it's not enough to pick based on the pathogen. The host matters greatly. Important considerations are: number one, organ function, especially renal and hepatic. Because many antibiotics are eliminated via kidney or liver, impaired organ function may necessitate dose adjustments, such as reducing the dose or prolonging dose intervals to avoid toxicity. Now, age and physiologic status. Pediatric, elderly, pregnant, or critically ill patients may differ in drug handling, such as in absorption, distribution, clearance, necessitating individual dosing. Now, allergies or prior intolerance. A careful allergy history must be taken, and alternative agents should be used if necessary. Fortunately, there are many antibiotic classes to choose from. Next, prior antibiotic exposure and colonization history. Recent antibiotic use can select for resistant organisms. Prior colonization or local epidemiology may increase the likelihood of resistant pathogens, which should influence empiric therapy choice. Now, the site of infection and drug pharmacokinetics. As already discussed, drug penetration to the infection site, local tissue environment, and presence of foreign materials like catheters, hardware, biofilms may influence agent selection, route, whether IV or oral, and dosing. So in many serious infections, especially at first presentation, intravenous or IV therapy is preferred due to concerns about absorption, distribution, achieving adequate serum or tissue concentration, and patient stability. Once patients stabilize and show clinical improvement, or when treating less severe infections, oral therapy may be used, provided the chosen antibiotic has good bioavailability and achieves adequate serum or tissue levels. This helps reduce cost, risk of IV-related complications, and may facilitate earlier discharge. For prolonged treatment courses like osteomyelitis, endocarditis in stable patients, outpatient parenteral antimicrobial therapy or OPAT can be considered, provided that the antibiotic allows feasible dosing frequency, has stability for outpatient infusion, and toxicity is manageable. But for certain infections like CNS infections, complicated deep-seated infections, poor bioavailability, or poor penetration, IV therapy may need to be maintained throughout the course. Alright, so now we go to therapeutic drug monitoring or TDM. So, an important aspect of safe and effective antimicrobial therapy is knowing when to monitor drug levels in the patient. Some antibacterial or antimicrobial agents have a narrow therapeutic index, meaning the margin between effective dose and toxic dose is relatively small. In these cases, therapeutic drug monitoring becomes very useful to balance efficacy and safety. So classic examples are glycopeptides like vancomycin and aminoglycosides. These require TDM because of potential nephrotoxicity, ototoxicity in the case of aminoglycosides, or subtherapeutic exposure in the case of vancomycin when levels are too low. In critically ill patients whose pharmacokinetics may be altered, changed volume of distribution, renal function, fluid shifts, standard dosing may lead to suboptimal exposure or increased toxicity, further supporting the role of TDM in individualized dosing. Thus, while many antibiotics have wide therapeutic windows and are safely dosed with standard regimens with adjustments for age, weight, renal, or hepatic function, for others, TDM is a key tool to optimize therapy. So let's examine TDM in practice. So for vancomycin, when used IV, especially for prolonged therapy or in outpatient parenteral antimicrobial therapy or OPAT, serial monitoring of serum trough concentrations is recommended. In stable patients with normal renal function on vancomycin, weekly monitoring may suffice. But in patients with unstable renal function, critical illness, or on prolonged therapy, more frequent dosing is warranted. And this is an example of the most recent way of monitoring vancomycin. So we still order the trough right before the fourth dose in those with good renal function. But then nowadays we use the AUC, the area under the curve under the MIC, or above the MIC, and we use the vancomycin calculator. So you should learn how to do this in the clinics or on the floors. Now for aminoglycosides, TDM helps avoid accumulation that increases risk of nephrotoxicity or ototoxicity. Trough levels are especially important, and audiometry may be considered when courses are long. So more broadly, TDM, often within a framework of pharmacokinetic and pharmacodynamic based dosing, has been associated with reduced toxicity, has been associated also with shorter hospital stays, better drug exposure, and fewer treatment failures in various settings. As such, TDM is a valuable component of rational antimicrobial therapy, especially in complex cases, prolonged therapy, or when narrow therapeutic index agents are used. Now, historically, many antibiotic durations were based on expert opinion and tradition rather than robust data. However, current evidence increasingly supports shorter durations or shorter courses for many uncomplicated infections. Example, uncomplicated UTIs, community-acquired pneumonia in appropriate patients, uncomplicated skin soft tissue infections, and other common bacterial infections. Shorter courses reduce risks associated with prolonged antibiotic exposure, adverse drug reactions, increased cost, and selection for resistant organisms. Conversely, serious or complicated infections like endocarditis, osteomyelitis, deep-seated abscesses, foreign body-associated infections often require longer individualized therapy, weeks to months, guided by clinical, radiologic, microbiologic response, and possibly expert opinion. So, clinical improvement remains the primary indicator of response, and that means resolution of symptoms, signs such as fever and hemodynamics, lab markers, white cells, inflammatory markers, procalcitonin, sometimes radiologic improvement. Radiology, though, often lags behind clinical improvement, so lack of radiologic resolution alone should not unduly prolong therapy. In bacteremia, especially when associated with deep-seated infection or foreign bodies, microbiological clearance, meaning negative cultures, is often a required criterion, especially for gram-positives. Persistent positive cultures may suggest an unresolved source like endocarditis, infected catheter, or emergence of resistance, both requiring re-evaluation. Now, follow-up decisions should be individualized, account for patients' comorbidities, immune status, infection severity, source control, and risk for relapse. So this is just an example of an algorithm on how to stop therapy. So focus on the lower half. Daily patient reevaluation, reassessing after 3 to 5 days of full days of antibiotic therapy if there's progressive improvement of clinical and lab signs of infection and absence of persistent foci of infection and SOFA decreasing, and this is because it is a septic patient. If yes, then you may stop antibiotics when the patient had received 5 full days of antibiotic therapy and procalcitonin has decreased more than 80% and or CRP decreased by more than 80%. And sometimes 7 full days of antibiotic therapy regardless of the biomarkers. So that's just one example. Using clinical, laboratory as your parameters for stopping antibiotics. Now, antibiotic allergy is often overreported and unverified. Many patients labeled as penicillin allergic are truly not allergic when formally tested. Only a minority, 10 to 20%, test positive on skin testing. So over-labeling can lead to unnecessary use of broad-spectrum or less optimal agents. Non-allergic toxicity is also common, often dose or duration dependent, and more likely when renal or hepatic function is impaired or in older patients. Examples: nephrotoxicity with aminoglycosides, hematologic toxicity when prolonged use of certain drugs, neurotoxicity, drug-drug interactions, especially with agents metabolized via cytochrome P450. Now, when prolonged systemic therapy is needed, for example, months, periodic monitoring, lab tests, drug levels, renal hepatic function, muscle enzymes if relevant, blood counts should be instituted. Also, be vigilant about drug-drug interactions, especially in patients on multiple medications like immunosuppressants, comorbid conditions. Now to foreign body biofilm infections. Implanted devices pose unique challenges. Bacteria may form biofilms, structured microbial communities attached to surfaces surrounded by protective polymeric matrix, making them more resistant to antibiotic therapy. In biofilms, metabolic activity, penetration of agents, and drug efficacy are often compromised. Some agents may be more effective, but often removal of the foreign body remains the definitive treatment. Long-term suppressive therapy is sometimes used when removal is not feasible, but success is variable and should involve infectious diseases expertise. So there on the right shows how biofilm is formed. It starts with the bacteria and they auto-aggregate, and then they establish themselves with increasing number of the matrix itself and of course the bacteria. Now the matrix increases even further as growth occurs. Bacteria, matrix, and all of the other factors increase in number until there is a mature biofilm that forms, and of course antibiotics have a difficult time penetrating this. Finally, it is crucial to recognize that rational, responsible use of antibiotics isn't just good medicine, it's essential for public health. So antimicrobial stewardship programs aim to optimize selection, dosing, route, and duration of therapy to maximize clinical cure or prevention of infection while minimizing unintended consequences, adverse drug effects, toxicity, cost, and emergence of resistance. So key strategies are as follows: evidence-based guidelines, de-escalation, IV to oral switch, limiting to the shortest effective course, TDM when indicated, careful documentation and review of therapy, multidisciplinary teams, and computerized stewardship tools. Stewardship not only improves individual patient care but also protects the broader community by preserving antibiotic efficacy, reducing selection pressure for resistant organisms, lowering drug-associated morbidity, and reducing costs. So we discussed this before, but I just wanted to show again the peak above the MIC. That's the vertical line going up. That speaks of concentration-dependent killing, while the time above the MIC, that's number 3, is the concentration above is not necessarily the driver of the killing, but it's the duration of time that the drug levels are above the MIC. No? And just to show AUC above the MIC, and this is how it looks. No? That's the area under the curve above the MIC. No? So that's still part of the concentration dependent nature of the antibiotic. No? So now just a bit on dosing adjustments in renal disease and kidney dysfunction. Clearance of antibiotics may be reduced, and this may prolong the half-life. So don't forget to check all the time whether dose adjustments need to be done. No? Now, in time-dependent agents, it's preferable to reduce the dose but maintain the dosing interval, again to maintain the time above the MIC, while concentration-dependent agents keep the dose but prolong the dosing interval because that's the driver of the killing. No? And yeah, you can get your own reference so that you can have a ready source on how to do renal dosing protocol. So why does all this matter in everyday clinical practice, especially for patients with kidney disease or in critical care settings? Traditional dosing that simply reduces dose or extends interval based on creatinine clearance or GFR or glomerular filtration rate without considering pharmacodynamic properties may lead to suboptimal efficacy if time or concentration dependent targets are not met, or risk of toxicity if accumulation occurs. In renal impairment, using pharmacodynamic informed adjustments improves the likelihood that the antibiotic will be effective and safe. And then for concentration dependent drugs, high peak concentrations with extended intervals may maximize bacterial kill and minimize accumulation in patients with reduced clearance. For serious infections or in patients with fluctuating renal function, pharmacodynamic-based dosing strategies, including extended or continuous infusions, adjusted intervals, loading doses may significantly improve outcomes. Overall, PK/PD should guide antibiotic selection and dosing, especially in non-standard patients like renal failure, dialysis, critical illness, rather than relying solely on standard regimens. Now, as we conclude this lecture, here are the essential points to remember about antibacterial therapy. Antibiotics remain our most powerful tools against bacterial disease, but their effectiveness depends not only on the drug, but on how, when, and to whom we give them. Over a century of antibiotic use has saved countless lives, yet emergence of antimicrobial resistance and changing patient populations challenge us to use them wisely. A deep understanding of pharmacokinetics and pharmacodynamics, PK/PD, how a drug moves through the patient and how it acts on bacteria, is critical to optimize therapy. The key pharmacodynamic parameters are peak concentration above the MIC, area under the curve above the MIC, and time above the MIC. Now, some antibiotics like beta-lactams or vancomycin are time-dependent. Their effectiveness depends mainly on maintaining drug concentration above the MIC, for a sufficient portion of the dosing interval. Others, like aminoglycosides, fluoroquinolones, are concentration dependent, and a high peak concentration or high AUC relative to MIC correlates with better bacterial kill. In special patient populations, especially those with impaired kidney function or undergoing dialysis, standard one-size-fits-all dosing may be inappropriate. Adjustments should reflect PK/PD principles, drug clearance, and patient factors to maximize efficacy and minimize toxicity. Rational therapy must also be guided by accurate diagnosis, microbiology, culture, susceptibility, or even the rapid diagnostic tests. Then de-escalate after empiric broad-spectrum therapy, and then de-escalate whenever possible. Optimize the route, IV versus oral, duration, and dosing, always balancing effectiveness, safety, cost, and resistance risk. Finally, preserving antibiotic effectiveness for the future depends on judicial use. Stewardship is not optional. Thoughtful prescribing, reinforced by PK/PD knowledge, diagnostic precision, and individualized patient care, is our best defense against resistance and therapeutic failure. So thank you for your attention. I hope this lecture helps reinforce a principled, science-based, and patient-centered approach to antibacterial therapy. I welcome any final questions or comments. But before leaving, if you want to watch this again, it's on the Microbiong Maliit Mini Micro YouTube channel. The handle is @minimicrobio books. There are many different other lectures there, including many different videos with regard to the books that I have written, and lectures and interviews that I've given. But if you also are interested in Catholicism, teachings, scripture, you may also visit Letters of Paul to the Philippines. The handle is @LettersOfPaulPH. One of the most recent videos that I did was the Immaculate Conception of Mary. How does the Netflix movie fare compared to true Catholic teaching? Again, this was the antibacterial agents lecture. Thank you again so much.